Welcome today to the Transplantation podcast. My name is Dr. Macy Levan, and I'm the social media editor for the Transplantation Journals. Today, I'm here to talk about sequential NRP and NMP in DCD liver transplantation. There's a lot of words here, an acronym. To get us started, I'd like to introduce our guest, the author of this paper, Dr. Rohit Gaurav. Can you tell us a little bit about where you're from and what you do?
Thank you, Macy, and a pleasure. And thank you for inviting me to this podcast. So, I am a transplant surgeon. My name is Rohit Gaurav. I'm based in Cambridge, Addenbrooke's Hospital, which is associated hospital for the Cambridge University. I do liver, kidney, pancreas transplants. So my background is I did my surgical and medical training in India, and then I moved here for the fellowship. And then I was appointed as a faculty in 2020. I joined the team, and that's how I started doing all the transplanting.
So you started in the middle of the pandemic or the beginning of the pandemic, I would say.
Yeah, that was quite interesting because my interview was on Zoom actually, because the face-to-face interviews were not allowed at that time. So yeah, I was interviewed during that time.
So let's get started a little bit with the basics. I read a whole bunch of acronyms and I know what they mean, but can you explain to our listeners what DCD donation is and particularly why livers from DCD donors have historically been so challenging to transplant?
So DCD is a type of donor which is donation after circulatory death. So there are two types of donors. One is a brain death, where a neurological criteria is used to declare death, and the second type is when treatment is withdrawal in control settings, and then we wait for asystole. Usually the standoff time is different in different countries. In UK, it's about 5 minutes. I think it's same in US as well. So
Yes.
after 5 minutes, death is declared by circulatory criteria, and that's how when we can proceed with the donation. So what happens with the DCD donation as compared to DBD is during that withdrawal of treatment, there's a lot of hypotension, hypoxia, anoxia because a donor goes through the death process at that time, and that affects the organ outcomes, especially liver, because liver is less resistant to hypoxia as compared to kidneys, which have a similar result between DBD DCD, but livers get insulted during this time, and that's how the results are not as good as if you compare DBD livers with DCD livers. They are more prone to biliary complications, especially ischemic cholangiopathy, because the artery supply to the bile ducts is mostly arterial, and that's get affected during this process.
Okay, so now tell me a little bit about normothermic regional perfusion or NRP and what problem was it originally designed to solve?
So normothermic regional perfusion is basically instead of as soon as the donor death is declared in circulatory death donors, instead of removing the organ and putting in ice, you basically start the donor on pump on normothermic perfusion, which is oxygenated as well. And that what it does is basically it restores the energy levels of the organ. We do it for 2 hours in UK at normothermic uh, perfusion. And that gives us a time to assess the organ as well, because you can see uh, uh, function of the liver mostly by lactate utilization. You can measure some damage markers like liver enzymes, alanine transaminase levels. And then at the end of 2 hours, you can decide whether to use this liver or not.
Okay, so before your work, what happened to a DCD liver that had suboptimal NRP parameters? Was it simply discarded?
Yeah, so initially we were quite strict because, as you know, when a new technique comes, you're quite conservative to start with. So you want better results for your patient, obviously. So we used to discard those livers because they were not working as per what our criterias are. But then with experience, even though this intervention is very novel, but then again, there are a lot of factors which can influence all the assessments, especially the lactate clearance, liver enzymes. So, so we decided that if the liver looks good, if it's a young liver and the appearance is acceptable, we should assess this first further on ex-situ, which is, taking out the liver, put it on machine at the recipient center or our center. And that's how we started. So initially we were a bit hesitant, but we started doing this, putting the liver on machine first as a research and then in clinical practice.
Okay. So let's talk about the why behind your paper. So that's what we do these podcasts for, is kind of like interviews with the author to understand, why you even did this work. So let's talk about the motivation and the clinical problem. So what was the clinical observation that made you think, hey, we need to try sequential NRP, then NMP? Was there a specific case or a specific moment that you kind of aha this?
So, Macy, obviously, the supply of livers, the availability of livers doesn't match the wait list mortality. There are still patients who are dying on wait lists waiting for livers. In UK, it can be up to 10% patients who can die. So obviously, we have to restore new sources of organs. We in Addenbrooke's Hospital in Cambridge, our waiting list is not, it's not too long. And what that means is the national allocation, we don't get offered DBD organs. So our main source is relying on these circulatory death livers. And obviously, we balance on the outcome of them. We started doing this NRP and NMP. In fact, we did our NRP first in 2010 and first transplant in 2011. And
Wow.
based on these years of experience, we have started doing these sequential uh, perfusions to decide whether to transplant or not.
Yeah, was there any resistance or skepticism from your team starting this in 2011, and then your paper reports the cases starting in 2017? But you go.
Yeah, so yeah, that's a good question. Obviously, there's always, those who are pushing the boundaries and those who are keeping checks and balances. So we have that in our unit as well. Especially a lot of resistance were there from the hepatologist, because obviously they have to face the complication caused by us surgeons. So yeah, so we even though we started in 2011, but we have to understand that the cases were not that many. In first 5 years, I think we were doing like in single digits, but then it went up quite quickly up after 2017 and 2018 when we saw our results, early results, of this NRP and NMP. So it's a work of years before me. Yeah.
So you've already really told me that the problem, at your center and nationally in the UK with the liver shortage and then discard of livers that could previously be utilized or now can be utilized with machine perfusion technology. Is has this completely persisted through your career so far? Do you think this moment is a way to change that?
Yeah, I mean, we are moving in UK, we are moving towards, NRP for all the DCD donors. I know this is a requirement in, some of the countries, especially Spain and France. But I think in the UK, there's a move towards that as well, that all the DCD donors should proceed through NRP. And I know that in the US, there's a lot of work going on this as well, and they have done increased manifold in last 5 years. So I think that's a very good in situ, in donor intervention, which can affect outcomes of not just the liver, but other organs as well.
Yeah. So let's talk specifically about your science and your study and the key findings. So, can you walk us through what actually happens operationally? So, how does a liver go from NRP on the donor to NMP at your center?
So what happens is in UK, there are specific retrieval teams. There are 7 or 8 retrieval teams in the UK. Uh, when there's a donor, and DCD donors are mostly either regional, they are specified regions, So a team is sent out. So usually it's our team which goes out to do this NRP in a donor at a donor hospital, which can be several, 100 miles maybe. And then we bring the organ back to base if we feel that uh, it needs further assessment, or if it's suitable for transplant, and obviously it goes directly to the recipient. But if we feel that it merits further assessment, we bring it to Addenbrooke's Hospital. We have a dedicated perfusion suite, and there we put this liver on the XC2 machine, which is again a normothermic. We don't use hypothermic. I know there are other teams which use the other perfusion modalities as well, but we use normothermic for two reasons. One is because it gives you assessment as well. You can assess organs on normothermically perfused livers, and once the parameters are back on machine, and when the team feels that it is an appropriate organ, sometimes we do a mini MDT because you need more than one surgeons to decide whether it's an appropriate organ. In fact, hepatologists, anesthetists, uh, and then we decide to go ahead with the surgery. So there's a lot of case selection, yes.
Okay. And so you divided cases into two groups, right? You have this donor indication, NRP and NMP, and then recipient logistics, NRP and NMP. Can you explain the distinction between those and why it matters?
Yeah, so the reason for this distinction is because both the indications are quite different. So there's one indication where actually the donor liver itself needs further assessment because either we couldn't do NRP for 2 hours or the parameters were not as per our understanding at the end of 2 hours, and we want to assess this further. We want more assurance, before putting it on. That's the donor indication. So here the liver is a high risk liver. A second indication is a recipient indication. So a recipient can be a retransplant, maybe had a previous multiple surgeries, or they might we want to cut short the cold time. The amount of time a liver can sit in the ice box is limited. So to buy a time, so it's a preservation modality as well. So in these difficult recipients, or you're waiting for a biopsy or theater logistics, in COVID pandemic, ITU were not available. So we had to put livers on machine, or if you're planning for a daytime transplant in a complex patient. So in those patients, the liver is put basically to buy time.
Okay. So your headline finding that I could come up with was that two-thirds of livers that failed NRP lactate criteria were ultimately transplanted successfully after NMP. How surprising was that to you?
Correct. So I think we knew that lactate, even though we prefer to see a downward lactate trend in the donor during NRP, but we know that there's a lot of confounders at that time because first thing is you're not perfusing the whole body because there are areas which are under perfused which may be making lactate, or you might have given too much of blood because there was too much of blood loss. So this is not a perfect science. So even though we prefer lactate going down, but it may be that the liver is good, but 2 hours may not be enough time to assess, that trend in the lactate. So that's how we started doing this. But the most common reason was a lactate not falling down at 2 hours.
You even transplanted livers with ALTs of over 1,000, right? During NRP. And that seems counterintuitive. What does that tell us about how we've been interpreting NRP parameters?
Yeah, that was a surprise. Actually, we had four such livers and we did three. In fact, we have done a couple more after this study. So what happened is it's it's a young donor. Yeah, so obviously young donor. They were fit and healthy before the donation. Uh, it looks good during NRP, but the lactate is not doing, or the ALT is, maybe out of our parameters, which we take as 10 times the normal level of 500 units, per liter. That's what our cutoff is. Some of the countries, specifically when they do uncontrolled, they take 1,000 as cutoff. But I think ALT above 1,000, accepting it is a rare thing. But because they were young donors,
Mhm.
liver looked good. We thought that why not, assess it further on NMP, and obviously they met our criteria. So, and that's how we ended up transplanting. But we
When
have
you
burnt our fingers as well.
when you say your criteria, are you talking about a center criteria or are you talking about a country criteria? It's just so for national allocation policy.
Yeah, so this started as our center criteria, but now this criteria is a national protocol. So now there's a national NRP protocol in UK. All these parameters which are assessed during donation, they are filled in a passport. Basically, it's a paper where all these parameters are filled, and that travels with the organ to the recipient center. So it started as a institutional, but then it has become as a national guideline, basically. Yeah.
Cool. So let's talk a little bit more about these details. The glucose metabolism data on NMP seems to be a key viability signal. Can you explain to me what you're measuring and why bile glucose in particular matters?
So glucose, we measure perfusate glucose, and as well as the bile glucose as well. In our studies from NMP, we have seen that this is an important criteria, whether the liver is utilizing the glucose or not. And it depends on the physiology of the, utilization of zone 1 to zone 3, which is more active. Uh, and we have seen that the usually after hour or two, usually the glucose declines because the liver starts has converted all the lactate into glucose first, and then it's storing as glycogen, and that's how it drops. So this is a useful parameter we have seen, and that's what happened in the liver actually, which we missed actually.
Okay. So let's talk about the one case that didn't go well. Some of the lessons learned from primary non-dysfunction. So you had one case of primary non-dysfunction. You want to walk us through what happened and what were the warning signs that maybe in retrospect might have you acted differently on, or what can you teach us about this approach or limits to this approach?
Yeah, so we had this one primary non-function basically. So this was a young donor. Obviously, liver looked pristine, but it didn't work that well on NRP. The lactate was basically static; it was not coming down, and the ALT was more than 1,000. This is one of that four cases we have done over 1,000 ALT. Because the liver was young and healthy, we decided to proceed for assessment. We brought it at our base and we put it on machine. Uh, Lactate fell. Uh, the one thing about lactate is because it's a closed one organ system, even few hepatocytes can metabolize lactate very quickly. So you don't need that many functioning liver to metabolize lactate. So it's a very sensitive thing. So the lactate came down. ALT on machine was, I think it was at the upper level of what we usually accept. We usually accept 6,000. It was at that level. The one thing which we missed was the glucose. It started with a low glucose. We gave a challenge to a bolus glucose to challenge the liver. It didn't utilize that, and this was our experience at that time. We thought we didn't know about the importance of glucose. That in hindsight, if that liver comes now, obviously we won't be transplanting that because of the importance. But that's how we learn. The important thing is because of these machine perfusions and normothermic and regional perfusion, the PNF events are very low. So each event you have, you learn more from them. They are
Sure.
very rare events now for a single center to learn. So I think more collaboration with the reasons of PNF in these machine perfusion organs will be good.
Okay. So let's talk now about the outcomes and implications and sort of what does your data mean? So I want to talk about the early outcomes. So EAD rates and AKI were worse in the sequential NRP NMP group compared to NRP alone. yet 3-year survival was equivalent. So, how do you reconcile that in terms of an early outcome with EAD and AKI?
That's correct, Macy. So what happened is obviously the early outcomes, if you compare the sequential versus standalone NRP, is worse. But then we have to consider either it's a high risk donor or it's a high risk recipient. So these are, it's a combination of two which we are using. And even though this was higher, but if you compare with the standard DCD, where none of these techniques are used, they are much better than that because it works in them. But that doesn't translate to the long-term survival because you see the results are pretty similar actually if you see the graft survival and the patient survival. So yes, they do struggle a bit initially in the post-transplant period, but the long-term results is similar uh, as the outcome.
Okay. So, notably, none of the non-anatomic strictures, I'm not probably even saying that right, in your sequential group required any intervention. That's really remarkable, right? Given how feared NAS is in DCD transplantation. So, what explains that? And maybe you can pronounce it better than me.
It's known by different names. Yeah. So NAS basically is the Achilles heel in DCD liver transplantation because this was the main thing which was keeping DCD liver transplant, not growing. Uh, in all the NRP data from all the countries, whether it's Spain, UK, US, if you see they have very low NAS incidence. In
Okay.
fact, many papers say 0%, which is not possible in medical science. 0% is, it's difficult. So yeah, so rates are very low. In our cohort, the one with the sequential, we saw around 6% NAS. We don't do routine MRCPs, and these MRCPs were done only when they were clinically indicated. Most common was raised alkaline phosphatase, and that's how when the MRCP picked up few strictures in the periphery, uh, but they were not clinically relevant because none of them required any intervention. No one had any ERCP, no dominant stricture was treated, or none of them required any retransplant or graft failure, which is remarkable actually, which is the same as all the NRP data we have till now.
Wow. You also mentioned that NMP may blunt post-reperfusion syndrome in sicker recipients. Can you explain what post-reperfusion syndrome even is and what that means clinically and really why it matters?
So we have published this before, comparing the post-reperfusion syndrome uh, between a standard DCD and an NRP and NMP livers. And what happens in post-reperfusion? Reperfusion is basically when you connect the donor organ in the recipient and remove the clamps off to supply the new liver. And what happens is because the liver was sitting in icebox, maybe it has, uh, built up toxins and that was released instantaneously into the recipient at that time. They have this hypotension at that time, and sometimes they may can have cardiac arrest as well, basically. So this is a feared by the anesthesia actually colleagues because post-reperfusion syndrome. um, and what we have seen in NRP and NMP is because of the superior, preservation techniques, these livers, they don't build up that much toxins during this preservation, and they reperfuse more smoothly as compared to the and in fact, now when we have a sicker recipients, those who are already in ITU or those who are on maybe filtration in ITU, we electively use this machine to reduce the post-reperfusion syndrome. So
Hmm.
that's
Wow. Pretty cool, huh? Pretty cool. All right. Let's talk now a little bit about the bigger picture.
yeah.
So this is things like policy, practice, and where we're headed in the future. So, if every transplant center adopted this approach, what do you think is a realistic increase in usable DCD livers?
So obviously the decline rate is high. In the UK, before these uh, machines were used, uh, only 30% of the DCD donors were used, and they had more than three times the decline rate if you compare with TBD.
Okay.
If you use these, we have seen that you can increase the utilization to up to almost 70 to 75%. That what the study also showed. And that is increasing our utilization if you compare with, standard DCD. And that will translate to many more organs, which we will be able to use in future. Obviously, we still don't do NRP in all the DCD donors, but obviously we are moving towards that as a national, uh, probably in next year, in a couple of years, we will be aiming to do, NRP in all the DCD donors.
Wow. Okay. You also mentioned a growing interest in daytime transplantation for high risk recipients. So, how does NMP enable that logistically?
Yeah, so that's interesting because obviously in daytime you have more personal, hospital, you have more resources available in the daytime. In the nighttime, it's always, it's tricky to reperfuse these high risk organs or high risk recipients in the night. Uh, so now what we do is if we feel that the recipient is a high risk, and if the organ is arriving after, say, maybe late night or early morning, we put it on machine, and then we electively start. If it works well on the machine, we start, at 8 a.m., 7 a.m. Start. And basically it's driven by anesthesia team as well, because my anesthetic colleagues, they usually like, doing on these high risk recipients where you have more, uh, assistance available.
Your center doesn't use hypothermic machine perfusion. Is that a deliberate choice? And do you think that HMP has a role alongside NRP?
So yeah, we don't do hypothermic. It's not. It's a historic. It's not by choice. We have always done normothermic perfusions. Hypothermic still has a role to play because uh, and one important is in those with the recipient or logistic reasons, because in them you can put the organ on hope, which is as good as uh, NMP, because you don't want to assess this. Now, some of my colleagues will say they are still developing assessment on hope, but it's still not up to the mark as of now, maybe in future. But if you need to assess an organ, you need to bring the organ to, metabolically active state. And you can do that only when the liver is, oxygenated and normothermic temperatures. There are still studies going on hope groups as well for assessment, but I think its role is limited as far as assessment is concerned. But for logistics and recipient matters, yeah, it has equal. Yeah.
Okay. So, where does this go next? Are there randomized control trials that are feasible here, or what would you want to actually study?
To make RCT, it's difficult for an endpoint because the results are so good. If you want to make NAS as the endpoint, you will need thousands of patients because the difference is so. Uh, and and some may say that it is unethical as well, because it's a superior thing. You know why you're comparing. Why will you give someone a inferior treatment? So RCT is difficult in our setting because we won't be able to go back doing this standard DCD. All our DCDs have some treatment since 2019. I think it was the last when we have used a standard DCD. We have not done any standard since then. So I don't think we will be going back. So RCT is difficult, but then there are a lot of studies on NMP because it's a platform where it's a good intervention. You can do a lot of research. You can modify organs. You can gene therapies and all those things. I think that's what will come in future for sequence. But we won't be doing RCT comparing to standard DCD.
Okay. All right, now I have a couple personal questions for you. So, is there a patient case from this series that stays with you, like one that represents why this work matters so much?
Uh, I remember still this some of the livers with more than 1,000 ALT and a lot of discussions whether to use or not use, and then going back to the basically open discussion with recipients that this is a good liver, looks good, young,
Mhm.
but we have doubts whether you want to go ahead. I think it's the on the recipients, they understand that they want to take these risks because they understand. So I think talking with the recipient, if you tell them all the details, they are quite open to undertake all these, risk. And I think those moments where all the discussions and all those things are quite critical. Uh,
Really, just the communication with the patients and sometimes the uncertainty, talking about uncertainty is
Yeah,
okay.
because you are telling someone things which you are not sure yourself, and then you have to take them into confidence. So
Right.
those sort of things, yeah.
Very important. That's a big part of my work. I love that piece. So, what would you say to a transplant surgeon at a center that isn't yet doing NRP, NMP, who's skeptical about complexity or even the cost?
If you come, I'll come to the cost first, and then so cost. If you compare basically the cost of keeping a recipient on a wait list with repeated hospital admissions, all those, and then after surgery, dealing with all the complications, especially the biliary complications, that is the cost we are comparing against these machine costs. In UK, we do back to base perfusion. Basically, we don't carry the NMP to the center, which is done in US actually, which is more costly than back to base approach.
Hmm.
So it's a different, setup. But for us, if you compare cost of the intervention with NRP and NMP, is much cheaper than treating a patient with repeated hospital admissions, repeated ERCPs, MRCPs, and all those things. So comparison is quite straightforward. Mhm. And then you said if a new surgeon wants to do these things, I think the results are so compelling if you see, and if you have, if all your donors are DVD, I will say, yeah, just keep on doing DVD. But then if you're struggling with your waitlist mortality and your waiting list is going up, I think it's better to use these interventions and increase your donor pool. And they do require a bit of logistics, but once you get used to doing all these things, I think it's much straightforward than managing all the complications.
Yeah, of course. All right, last question for you. What's the one thing that you want listeners to take away from your paper?
I think the one thing which I said that these obviously there is a lot of skepticism, like whether these sequential, because these are all high risk donors, and whether you want to proceed with them or not. I think you need to make a case selection because you can't put a high risk liver in a high risk recipient. So you have to match that as well. So case selection and all those things are important. And they can give you a good results if you have done, better matching, better case selection according to that. Yeah.
Fantastic. Well, thank you, Rohit, for spending some time with me. The paper Sequential in situ normothermic regional perfusion and ex situ normothermic machine perfusion in controlled donation after circulatory death in liver transplantation, a retrospective single center experience. It's a lot of words. That paper is now available live in the Transplantation Journal, and you can check that out along with this podcast. To all of our listeners, thank you so much for taking the time to meet with me today and to share your behind the paper insights. It's Macy Levan with the Transplantation Podcast. Thanks so much.
Thank you, Missy.